Hi, everyone. Good afternoon. I didn't realize I'd been rambling to myself in the last 1 minute. Okay, so thanks for having me again. This afternoon, we're going to be discussing hematological disorders. And under that topic, we're going to be taking two subtopics, anemias and sickle cell disorder. These are two very important topics since it's a feature in most of the diseases that are found in sub-Saharan Africa. It's a disease of nutrition as well as a disease of chronic durations. So you find that a lot of people with infections with that affect nutrition or poor nutritional status have features of anemia. Sorry, just to mention, for anyone that has questions or comments or contributions, you can put them in the chat area. I will be watching that as well as, giving responses to questions you have in that comment. So, then as well as, so I've mentioned infections and nutritional challenges, then as well as in the area of patients with long-standing conditions. So some of those long-standing conditions could be cancer, could be other conditions like hypertension, diabetes, including sickle cell disease as well. So anemias are very important in terms of health management for sub-Saharan Africa. Now we're going to look at two different classifications. One is a general and more in-depth classification based on function. And by way of defining anemia, right? It's a group of diseases characterized by decrease in hemoglobin or red blood cells, resulting in decreased oxygen carrying capacity of blood. And that reduction in oxygen carrying capacity of the blood is what really leads to all of the signs and symptoms that are noticed. So signs, for example, like, the dizziness, the smooth tongue, the lowered secretion of saliva, things like pale sclera of the eyes, right? Pica, the desire to chew on non-food items. All of those are part of the symptoms that patients generally show when they have anemias, right? So, okay, so on to granular definitions, right? The WHO just holds a general picture that when in male, you have hemoglobin level concentrations less than 13 grams per DL or, less than 130 grams per liter, 13 grams per DL, or less than 8.07 millimoles per liter in men. And then for women, less than 12 grams per DL and less than 120 grams per liter, right? Or less than 7.45 millimoles per liter in women, right? And this, I'm going to talk about the symptoms real soon. So in terms of functional classification, you have hypoproliferative symptoms, hypoproliferative class, including those resulting from bone marrow damage, iron deficiency. These lead to reduced stimulation, leading to the anemia, anemic condition. So for example, renal disease can lead to reduced stimulation of the bone marrow. Inflammatory conditions or inflammatory states generally lead to anemia as well. And then metabolic disease. That's a metabolic disease, for example, like diabetes, like I mentioned earlier on, can lead to hyperproliferation and lead to anemia of hyperproliferation. And then those that affect maturation of the red blood cells, right? For example, cytoplasmic defects, like diseases like thalassemia, iron deficiency, or sideroblastic anemia can lead to poor maturation of red blood cells, leading to anemia, right? Some of the examples: folate deficiency, vitamin B12 deficiency, refractory anemia as well. And then hemorrhagic or hemolysis, that's where there's heavy blood loss, right? So from blood loss, from intravascular hemolysis, for example, that internal bleeding, autoimmune disorders can also lead to that. There's hemoglobinopathy as well, and metabolic or membrane defects. So those are based on function. And then if we look at based on the types of cells that are contributing to the anemia, right, can also be classified based microcytic, small cells associated with iron deficiency, normocytic, that you find the cells are normal size, but they're still anemia. Those are associated with blood loss or chronic disease states where there is low stimulation of the bone marrow. And then it can be macrocytic, where the red blood cells are larger than usual, or cells that are present are larger than usual. And these are associated with deficiencies of vitamin B12 and folic acid. In that case, the bone marrow produces those RBCs that are larger than usual, and in an attempt to help the body cope with the deficiency the body is experiencing. So you can have iron deficiency anemia caused by inadequate dietary intake, inadequate GI absorption, increased iron demand, blood loss, and chronic diseases. You can have B12 and folic acid deficiency anemias. You can have anemia of inflammation. Anemia of inflammation is a newer term, but it's used to describe both anemia of chronic disease and anemia of critical illness. For example, if you remember, we mentioned that something during the last class we talked, when we were talking about inflammation, we talked about an inflammatory state called cancer cachexia, and that's a generalized inflammatory condition that can also lead to anemia of inflammation. In fact, a lot of patients die more from the anemia of inflammation than just from the generalized anemic state. So it's hypoproliferative, that it suppresses the bone marrow's ability to produce red blood cells, and it's been traditionally associated with infections or inflammatory processes, tissue injury, and conditions that are associated with release of pro-inflammatory cytokines. It can be caused by chronic infections like TB, HIV, can also be caused by rheumatoid arthritis, and patients that present with systemic lupus erythematosus, SLE, and then, of course, cancers as well. There are age-related reductions in bone marrow reserve that can render elderly patients more liable, more susceptible to anemia, right? But most of them are often unrecognized diseases like nutritional deficiencies. And for children, that's pediatric anemias, often due to primary hematological abnormality. The risk of iron deficiency anemia is increased by rapid growth spurts and dietary deficiency. That's why for most children, because of the rapid growth from birth up until their teenage years, it's usually advised to supplement where there is no contraindication. In terms of clinical presentation, which with this come to the question asked earlier on that I should talk about the symptoms, signs and symptoms again. So the signs and symptoms depend on the rate of development, age, cardiovascular status of the patient. For acute onset anemia, most of the time, the heart symptoms you find is fast-paced heartbeats, tachycardia, lightheadedness, and breathlessness. So it's a very common symptom. In fact, most people's first symptom that probably, piques their interest and gets them to notice that something is wrong is probably lightheadedness and breathlessness. Now, for chronic anemia, it's more characterized by weakness, fatigue, headaches, symptoms of heart failure, vertigo, faintness, cold sensitivity, pallor, that's change in skin color, and loss of skin tone. So the skin becomes saggy, right? Iron deficiency anemia is more characterized by glossal pain, that's pain in the mouth, smooth tongue, that's the tongue loses its groove, right? There's reduced saliva flow. There's pica, which is compulsive eating of non-food items. And then there's this desire to always chew on ice blocks as well. Pagophagia, which is a compulsive eating of ice. And most of this is seen when anemia is present, right? Now, when chronic anemia remains for a long period of time without intervention, there are neurological effects, right? And the neurological effects are numbness, ataxia, right? When it is B12, usually numbness under the feet, in the arms, in the hands, rather, not arms, in the hands, under the feet as well. These, are related to B12 deficiencies. And then there can be psychiatric findings as well. Irritability is very common, depression, memory impairment, all these may occur with B12 deficiency as well. Anemia with folate deficiency is not associated with neurological or psychiatric symptoms. That's a very important differentiation. In terms of diagnosis, I am not aware that there is any point of care testing device that is currently used to test for anemia. If you know of any, you can let us know. I haven't seen any personally, but I'm aware that there's a lot of efforts to develop quick, what's it called? Quick point of care testing devices that will be able to run some of these tests. Now, initial evaluation of anemia involves a complete blood count. Almost everybody in this class would have had a complete blood count at one point or the other, right? And once a complete blood count is done, it's usually done under a microscope, right? And statistically, you are given a result. Now, from that result, you can diagnose if there's anemia or not. The general index for algorithm for the diagnosis is as presented here, but it's only for information purposes. I will not ask you about that to your pharmacist. Basically, what we do is work with the information from the laboratory part, or work with the clinical symptoms to, that we work from the symptom to physical appearances. For example, it's easy to identify change in the color of the sclera of the eyes, right? That's when you pull down with your index finger at the sac beneath the eye, right? You can easily identify paleness. You can easily identify changes, right? Compared to, and then work that with the presenting symptoms to identify anemia, rather than say, use this index, this algorithm with the tests, right? So, like I said, that's presented purely for informational purposes. In terms of treatment, goals of treatment are very important. If you remember, I have stated right from the time I started talking to you in this class that goals of therapy, goals of treatment are like the holy grail for what we do as pharmacists. So they are very key. There's no way you can escape them. both in practice and in examination, right? So goals of treatment are to alleviate signs and symptoms, correct the underlying etiology, right? For example, restore substrates needed for red blood cell production, like the cyanocobalamin, that's the B12, or restore the folic acid, or provide iron for people with iron deficiency anemia. Replace body stores. So as soon as the person begins to improve, it's not when you remove treatment, right? There's a scientific way to go about it where we know that, okay, the body's storage, right, for ferritin or the B12, that the body storage of these essential substrates has been replaced. And then, you now take the patient off the treatment, or prevent recurrence of anemia. For example, after providing treatment, right, after alleviating signs and symptoms, if the underlying etiology cannot be corrected, then you have to institute a maintenance dose that ensures that the patient does not lose, does not revert back to the anemic state again. Now, let's quickly take iron deficiency anemia as the first class we're looking at, right? For iron deficiency anemia, just as the name states, you already understand that the reason for this is iron deficiency. Now, because of how common iron deficiency anemia is in sub-Saharan Africa, we have come to the point where whatever medicine you're using to treat one type of anemia has some features of other kinds of anemias and treats them alongside. Now, it's not something that's regular everywhere in the world, right? You don't just find someone being given iron for their iron deficiency anemia in the UK, and then they're giving them maybe cyanocobalamin as well, right? It doesn't happen like that. So if you're being treated for iron deficiency anemia and none of the other substrates feature in your deficiency, you're only supplemented with what is missing. But because we have less access to testing, less access to definitive diagnosis, right? It's more common here to have, one supplement that contains both iron, folic acid, cyanocobalamin, contains a number of other substrates as well. I hope that's clear. But when we're discussing these treatments, right, understand that we're targeting each of the deficiencies as they appear. So if I ask you about specific anemias, don't come and give me Boniche, because that's the way it appears in the market, right? I'm going to give you specific ones and how to treat them, and then please ensure that you follow closely, right? So like I mentioned, iron deficiency anemia, the substrate that it's missing, it's iron, right? Ferrous salts. So the basic thing done with iron deficiency anemia is to supplement with ferrous sulfate, right? So there are the ferrous sulfate available. They're not enteric coated and they are immediate release. And they usually are 200 milligrams of elemental iron or slightly less, about 158 milligram in some of the capsules, right? And they're usually taken in 2 or 3 divided doses throughout the day. But also because of the side effects, which is they sometimes cause irritation in the GI, so they are recommended to be taken with meals. Iron is poorly absorbed from vegetables. Please, when you post questions, please always post it to the general so everybody can see it. right? So this question says, if you give an IDA patient a supplement that contains all substrates like iron, folic acid, B12, and the likes, isn't there a possibility of contraindication since the patient only needs iron? There is a possibility, which is why we talked about the fact that this treatment is only a feature of our environment. It's not a general state. Take, for example, patients with sickle cell disorder are advised not to take iron, regularly, right? So for some of those patients who have iron contraindication, there are other supplements that contain substrates like the vitamin B12, contain amino acids and other substrates, right, that can help treat their anemia. Okay. Okay, so I was mentioning that iron is poorly absorbed from vegetables, grain products. You usually get what you need from all of the meals, right? But compare what you absorb compared to what is present in the vegetables, in the grain products, dairy products, and eggs is low. What you absorb is low, but the truth is, you absorb, usually when there is no disease, it means that you are absorbing enough to satisfy your daily requirement, right? And then the fact is also that your body also stores iron as ferritin, right? And when there are mild deficiencies, your body's store of iron is able to cover up for the deficiency. So usually iron deficiency anemia, for iron deficiency anemia to show up, means that your body storage of iron has been depleted. And that's why it's important to treat iron deficiency anemia, because the body will not naturally, recover from that. For patients with malabsorption diseases, it's always important to consider parenteral iron, that's injectable iron, or if they cannot tolerate oral iron therapy, right? So injectable iron, iron dextran injectable is often recommended. The dose depends on the cause of the anemia and the current hemoglobin concentration. There are about 4 formulations of parenteral iron dextran, sodium ferrigluconate, ferromoxitol, and iron sucrose. The 2 that are very common here in Nigeria is iron dextran and iron sucrose. Both are very available. So, and all have similar efficacy, though they have different side effects profiles. In terms of vitamin B12 deficiency, what is being recommended? Can you explain your question? What is being recommended? If you're talking about treatment of iron deficiency anemia, I mentioned it under my first statement. I said, as the name implies, iron deficiency anemia. So what you do is you supplement with iron. So if the person, most people, you recommend oral iron therapy, but if they cannot take the oral iron therapy, that's the ferrous sulfate, either as tablets or as capsules, then you recommend injectable parenteral iron. If that doesn't satisfy your question, please, you can come again. You can ask again, right, in a clearer form. In terms of treatment for vitamin B12 and folate deficiency anemia, for vitamin B12 deficiency, of course, is supplementation with cyanocobalamin. Right? Supplementation with cyanocobalamin. Oral B12 supplementation appears to be as effective as parenteral. So usually there is no need. You're asking the same question I mentioned earlier on. I said IDA It's not that. If you look at the physical features, you may be able to differentiate it, right? You can differentiate folate from B12 deficiencies, but in terms of iron deficiency anemia, you can only differentiate. It's hard to differentiate iron deficiency anemia from all the others because the features are very close with it's very prevalent, but the features are also very close. So usually it requires laboratory diagnosis. I've mentioned that as well before. So you can differentiate B12 from folic acid, but identifying iron deficiency anemia usually requires laboratory diagnosis. But in terms of if you identify anemia in a patient, right, first and foremost, you can, if there is no, remember what I said when I was talking about the nature of our care in sub-Saharan Africa. I said that because anemia is prevalent and because access to testing and diagnosis is also very low, once you identify anemia, right, you can institute treatment with the combination hematinics that are available here. Okay, please stop posting your names and matric number. There's nothing I'm using that for. Okay, so in terms of B12 deficiency, it's treated with oral cobalamin, and oral cobalamin in preference to the parenteral because the absorption, they are both as effective, even when the patient has long-standing pernicious anemia, right? It's essentially the same. The plasma levels are essentially the same, and you get as much response to oral as long as the patient can take oral cyanocobalamin. There is no need to give parenteral, right? Except when neurologic symptoms are present. And of course, remember we mentioned that neurologic symptoms do not show early on during treatment, during B12 deficiency. So except when neurologic symptoms have shown up, oral and parenteral are equivalent. But when there's neurologic involvement, then you will get faster response and less inconvenience to the patient with parenteral cyanocobalamin. And it's usually dosed at 1,000 micrograms for 1 week, daily for 1 week, and then weekly for 1 month, and then just monthly until the symptoms resolve. For patients with folic acid deficiency, oral folic acid, even though it's available as 5, 1, or 400 micrograms, most patients do not require more than 400 micrograms daily. It's only in patients who are people who are trying for a baby that it's recommended to use folic acid at up to 800 micrograms per day. That's about 1 milligram. But then the formulation commonly available in Nigeria is 5 milligram. So, it's still fine to use that. There are no side effects since it's mostly removed in the urine. Okay. 1 milligram daily for 4 months. But usually, like I said, 5 milligram is what's available locally. So there is no need to begin to look for 1 milligram, 800 micrograms. So just use the 5 milligrams. It's usually sufficient for treatment of folic acid deficiency anemia, unless the etiology cannot be corrected. For example, if it is malabsorption, if it is that, then daily dosing is required. For example, in sickle cell anemia, daily dosing of folic acid is required. Please, what is meant by B12 absorption pathway is independent of intrinsic factors. Means that the absorption of B12 and your okay, so for example, when you take medicines, after absorption of medicines, you there's distribution and then metabolism, right? So for B12, it doesn't undergo the first pass effect where about 80% of the medicine is either destroyed or converted to a proform, right? So with that, you do not get any loss of absorbed cyanocobalamin. So it goes straight into plasma and avoids the first pass effect that always occurs when you take medicines through the oral route. I hope you know what first pass effect is. Hello, I hope you all know what first pass effect is. Okay. This is why in this class you know about first pass effect. ADME is oh, okay, this is 300 level. Yeah, okay. Okay. So when you take medicines through the oral route, right? When you take medicines through the oral route, we assume usually that those medicines go from your mouth to your stomach, they are absorbed, and then they go into plasma, right? Where they can become effective. But the first pass route says that when you take medicines orally and it goes into the gut, about 80 to 90% of that medicine goes through the first pass effect, meaning that a huge percentage of that drug goes into, is transformed by a group of enzymes, right, to create something called the first pass effect. So only a small quantity of medicines that are taken by mouth end up in circulation, right? I hope you understand that. So that's called first pass effect. So usually, this is one of the reasons why medicines may be more effective at lower doses when you administer them parenterally compared to when you take them through the mouth, okay? They are transformed either to prodrugs or to inactive substrates, right? That's called first pass effect. Before they even get into the blood and now go back to be deactivated by the liver again, okay, or detoxified by the liver. That's called first pass effect. But then, that's not why we're here. So, like I said, oral folic acid, 5 milligrams daily, even though recommended is 1 milligram, but then what's available here locally is 5 milligrams. So, this is usually sufficient to treat the the folic acid deficiency anemia, right, and correct it. But like we said, if you can't correct, then you supplement regularly. Now, anemia of inflammation, right? We're not focused on what is causing the inflammation. We're just focused on the effect, right? The anemia of inflammation is less specific, right? And what we're focused on is reversing the, we're focused on correcting reversible causes, but our role in management of anemia of inflammation is to ensure that the body has enough of iron, right? And all the other substrates are not absent. So as the body is using them up during the anemia of inflammation, right, we are also not getting toxicity as well. So reserve iron therapy for an established IDA. Iron is not effective when inflammation is present. That's do not use iron therapy. Reserve iron therapy for an established IDA. Don't use iron. It's during IDA, if you remember at the beginning of the lecture, we mentioned that where is it? Suppression. Hypoproliferative, right? Inflammation is one of the causes, and what it does is it decreases stimulation of the bone marrow in its production of red blood cells. Okay, so reserve iron. See, we're not here to discuss fertility. You can check that up later. Yes, I said 800 micrograms daily, but then outside the scope of this class. So treatment of anemia of inflammation, right? Less specific, don't use iron therapy. RBC transfusions are effective, but should be limited, right, to episodes of inadequate oxygen transport. So that means as you're transfusing patients with concentrated RBC or plasma, you also continue checking for you use the SpO2 meter to continue checking the concentration of oxygen in the patient's blood, right? Then another group of medicines that are commonly used in anemia of inflammation are called erythropoiesis stimulating agents. Of course, you know erythropoiesis is that process of forming new red blood cells, right? So these agents can be considered in patients with anemia of inflammation, right? Examples are epoetin alpha, and the initial dosage is usually 50 to 100 units per kg 3 times a week, or dabipoetin alpha, which is given weekly. Now, ESA, that's erythropoiesis stimulating agents, may result in iron deficiency, because during anemia of inflammation, remember I just mentioned that it's due to suppression, not due to absence of substrate. But if you now stimulate the bone marrow to produce more red blood cells, you may end up using up the store of iron, right, that the body has kept and that is there, right? And if you use that up, then you need to replace as well. So ESAs may result in iron deficiency, and sometimes you routinely provide iron supplement when you start an ESA. Now, the toxicities that are associated with ESAs are sometimes part of the problems that limit their use. They can include increase in blood pressure to nausea, headache, fever, bone pain, fatigue, sometimes even development of occult cancers, right? That's been reported with epoetin alpha. I didn't say what anemia of inflammation is due to. I said its etiology is a lot. It can be due to cancers. It can be due to chronic diseases. It can even result from uncontrolled uncontrolled, what's this called? This group of diseases like systemic lupus erythematosus and co, right? Autonomic diseases, right? So that's what causes. But what I said is that anemia of inflammation results into suppression of red blood cell formation. So that's why we're trying to bring in an agent to stimulate that red blood cell production, right? So once you are instituting ESAs, you must measure hemoglobin level during therapy. Once you have an increase of about 12 grams per DL with treatment, or a rise greater than 1 gram per DL every 2 weeks, you may increase mortality, right, and cardiovascular events in that patient. So those are some of the side effects that are noticed again with erythropoiesis stimulating agents. If you're administering too rapidly, you can end up causing bigger problems for the patient. In patients with anemia of critical illnesses, parenteral iron is often used, but is associated with a theoretical risk of infection. How long should ESAs be used? It's usually up to the physician caregiver, but then as soon as you get the patient's hemoglobin level to, required levels, usually it is discontinued. I've observed patients on apoetin alpha for on and off for a couple of years, especially those with cancers. Daboetin alpha, not so much, but at least apoetin alpha, I've seen someone use for up to 2-3 years. Now, routine use is not supported by clinical studies. It shouldn't be used routinely because of the dangers that are also likely to come up. Anemia of inflammation, that's what AI means. Not artificial intelligence, please. Anemia of inflammation. I already, showed the short form ahead. Okay, now anemia in children, it's 2 types of prematurity and then in infants. So in prematurity, usually you use red blood cell transfusions. Off-label use means this is not the medicine. It means that the medicine wasn't specifically licensed for this indication, but we found that, for example, sildenafil was initially tested for portal hypertension, right? Which it works for, but then as a side effect, it increased sexual activity in those that were using the medicine before it now went back in for clinical studies and was now licensed for treating erectile dysfunction. So off-label uses are benefits that have been seen with the use of a medicine, but that was not the reason for which they were tested in clinical trials, right? And there has been no clinical trial done to show that or to get further license that this medicine can be used for that condition. Anemia of prematurity, usually treated with RBC transfusions, do not use ESAs. In infants of 9 to 12 months, administer iron once or twice daily between meals for 4 weeks, continue until you replace storage iron pools for 2 additional months, right? Dose and schedule of B12 should be titrated according to clinical and laboratory response for infants. Now, one of the things you notice as we've talked about this so far is that there is no duration of therapy for most of the treatments, right? We are saying treat until you get to a certain level, treat until you get to a certain point, right? So there is a need for monitoring therapy outcomes when you are treating patients for anemia. So for IDA, it's very important that, for all of the anemias, it's important that you commit this to memory, how to monitor treatment outcomes for each of the conditions, right? It's an integral part of the therapy outline for patients. So it's important that you note this. For iron deficiency anemia, we expect to see positive response to oral iron therapy in a few days, and then increase in hemoglobin by 2 weeks, right? And then you reevaluate the patient if reticulocytosis does not occur within that 2 weeks. You should have seen hemoglobin return to normal after 2 months of starting iron therapy. And then you continue for up to 12 months to replenish serum ferritin to ensure serum ferritin level has been restored to normal levels. For B12 deficiencies, that's the process of regenerating new cells, reticulocytosis. So for megaloblastic anemia, signs and symptoms usually improve within a few days after starting B12 for folate therapy, except if it's delayed and there's already neurologic symptoms. That can take longer to improve, or sometimes is irreversible. But then even if it is irreversible, right, you will notice that the symptoms will not get worse during treatment for you to be certain that this treatment is actually on, right? So for megaloblastic anemia, you should have reticulocytosis within 3 to 5 days. Hemoglobin begins to rise after 1 week, right? And then should normalize within 1 to 2 months. So similar to with IDA, requires about 2 months of treatment. Megaloblastic 2 requires about 2 months of treatment, even though you begin to see improvements within 3 to 5 days compared to 2 weeks with iron deficiency anemia. And then hematocrit level should rise within 2 weeks after starting folic acid treatment and should normalize within 2 months. So basically, for the substrates, usually within 2 months, there is within 2 months, hemoglobin levels are back to normal, but then there are variations in when you begin to see improvements in hemoglobin level. For when you use ESAs, right, you expect reticulocytosis to happen within a few days, within 24 to 48 hours. So you monitor the iron level, you monitor transferrin saturation and ferritin levels at baseline and periodically during therapy. Iron supplementation, like we said, it is arbitrary, but you should not wait until there is until iron deficiency anemia sets in before you begin supplementing for the patient. If you are using ESAs and within 8 weeks there is no improvement, then you should stop using ESAs. It means they are not effective for that group of patients. For pediatric patients, you monitor hemoglobin, hematocrit, red blood cells, 6 to 8 weeks after initiation of iron therapy. Monitor hemoglobin or hematocrit weekly in premature infants. Remember that for premature infants, you're not giving them any, what's it called? You're not giving them any substrate or ESAs. Essentially, you are transfusing red blood cells to premature infants, right? And then for those that are up to older and up to 9 months, right? Yeah. You also monitor for, what's it called? For those up to, 9 to 12 months, right? You also ensure you're monitoring hemoglobin and hematocrit weekly. So, sickle cell disorder. So let me give you 2 minutes to stretch the legs of your brain. So you can relax your brain for about 2 minutes. No, you cannot say that the patient will not fall back into anemia except you have actually, what's it called? Except you have corrected the underlying condition. You cannot say that the patient will not fall back into anemia. So you correct the underlying situation, replenish, what's it called? Replenish body stores, and then that can guarantee that the patient will not fall back into anemia. So if you actually identify the right cause of the anemia, then the patient will not fall back into anemia. I mentioned this thing when I was talking now. Don't worry, you will replay the videos and you hear them. Sickle cell anemia. Let's see how quickly we can run through that. All the short forms, I mentioned them now. So I won't go back on that again. Sickle cell disorders. For infants, where you can't replenish body stores, should RBC transfusion stop or? No, it's not infants that we talked about. Sorry, for infants, you can replenish RBC stores. It's in premature infants, premature babies that we talked about only RBC transfusion. It's premature infants that we talked about RBC transfusions alone. Premature infants are not small babies, right? A lot of what they require to handle xenobiotics are not present in them, has not been fully formed in them. There's no functioning liver at that point. There's no nothing to essentially, kickstart that process of detoxifying those substrate or drugs when you introduce it into their body. So the solution is transfusion. So you monitor, transfuse, monitor, transfuse, monitor. So sickle cell. Sickle cell syndromes can be divided into sickle cell traits. Those are the carriers, and sickle cell disease, which is a full-blown SCD, right? These are hereditary conditions, and they're characterized by presence of sickle hemoglobin in red blood cells. Just a minute, okay. Now, when someone is a carrier, right, that's a heterozygous inheritance where they have one normal beta hemoglobin gene producing hemoglobin A, and one sickle gene producing the hemoglobin AS gene. The hemoglobin S, which is the HBAS gene. Now, individuals with sickle cell traits are asymptomatic. It's individuals with homozygous HBS, which is the HBSS gene, that are historically been referred to as sickle cell anemia. Okay? The sickle cell anemia is different from the carrier. The carrier can pass it on. If the carrier marries another carrier, right, they are likely to produce someone with the sickle dominant gene, which is the HBSS, right? So this is one of the reasons why we do genetic counseling in Nigeria, that if you want to marry, ensure that you do genetic testing to identify that your partner is not a carrier if you are a carrier as well. Now, let's quickly look at the pathology. That's a disease pathway. Clinical manifestations of sickle cell disease happen because of impaired circulation, red blood cell destruction, and stasis of blood flow attributed to disturbances in RBC polymerization and membrane damage. Okay, so there can be clumping of sickled RBCs leading to impaired circulation. Polymerization, just a minute, please. All right, thank you. Back. Right, so polymerization allows the oxygenated hemoglobin to exist as a semi-solid gel that protrudes into the cell membrane, distorting RBCs into sickle shapes. Those sickle shape RBCs increase blood viscosity and encourage sludging. Sludging means they clump and adhere to the walls of capillaries and small vessels, leading to local tissue hypoxia. That's inability for those red blood cells to take oxygen to where they are needed, right? And this compounds the disease process. Repeated cycles of sickling upon deoxygenation and unsickling upon oxygenation damages the red blood cell membrane and causes irreversibly change in the shape of the red blood cell. These rigid sickled red blood cells are easily trapped, resulting in shortened circulatory survival and chronic hemolysis. Because these red blood cells are continuously changing and then they become deformed, right? This can lead to them, adhering together, breaking up. Once they break up, of course, that's hemolysis. That ends their life. But because of that change in their shape, they do not last as long as normal red blood cells. Sickle cell disease typically involves many organ systems, and clinical manifestation will depend on the genotype. Cardinal features are one, hemolytic anemia and vasoocclusion. Symptoms are delayed until 4 or 6 months of age, when the HbS, that's the sickle hemoglobin, replaces fetal hemoglobin. HbF is fetal hemoglobin. Common findings include pain with fever, pneumonia, splenomegaly, and in infants, pain and swelling of the hands and feet. Usual clinical signs and symptoms is chronic anemia, fever, pallor, that's change in skin color, arthralgia, pains in the joints, scleral icterus, abdominal pain, weakness, anorexia, fatigue, enlarged liver, spleen. We've said that before, splenomegaly. Okay, heart and hematuria. Acute complications, separate from the clinical signs and symptoms, right? Acute complications include fever and infections again, which is usually caused by sepsis, caused by encapsulated pathogens such as streptococcus, pneumonia. There can be stroke, especially in young adults. Respiratory symptoms like inability to breathe properly or breathlessness, and equivocal response to antibiotic therapy. These are common. Oh, thank you for the response. Okay. Sickle cell crisis can be precipitated by infection. What most people know about sickle cell patients, right, is called sickle cell crisis. It can be precipitated by infection, dehydration, stress, and sudden temperature changes. The most common type is a vaso-occlusive crisis, which happens, is manifested by pain over the involved area without change in plasma hemoglobin levels, right? Aplastic crisis is characterized by acute decrease in hemoglobin with decreased reticulocyte count, manifested as fatigue, dyspnea, change in skin color, and fast-paced heartbeat. Okay. Also, there can be something called splenic sequestration crisis, which is a massive enlargement of the spleen, leading to hypotension, shock, and sudden death in young children. And repeated insults to the spleen can lead to autosplenectomy, right? Where the spleen becomes basically unresponsive and unfunctional, right? So these incidents declines as adolescence approaches. So sometimes people who have repeated episodes have their spleen become inactive, and then the attacks reduces as they grow older. Chronic complications involve many organs: pulmonary hypertension, bone and joint destruction, eye problems, cholelithiasis, cardiovascular abnormalities, depression, hematuria, and renal complications. Then children may experience delayed growth and delayed sexual maturation as well. We mentioned earlier on that patients with sickle cell traits are usually asymptomatic, except for rare, painless hematuria. Diagnosis is by routine neonatal screening programs. And then laboratory findings that can point you to screening include low hemoglobin, increased reticulocyte counts, increased platelet counts, and white blood cell counts, and sickle forms on the peripheral smear when you're doing whole blood count or complete blood count. Treatment goals. The goals are to reduce hospitalization, reduce complications, reduce pain, and mortality. So the medicine used is tailored to those goals. Patients with sickle cell disease will require lifelong multidisciplinary care, and interventions include general measures, preventive measures, and treatment of complications and acute crises. For such patients, routine immunization will include immunization against influenza, meningococcal, and pneumococcal vaccinations. Prophylactic penicillin is usually recommended until 5 years of age, so beginning at 2 months or earlier until 5 years of age, right? Penicillin is usually given every 4 weeks, that's every month, through to 5 years. And then, of course, I mentioned this earlier on, folic acid is supplemented daily, recommended in adult patients, it's recommended in pregnant women and patients of all ages with chronic hemolysis. Treatments with fetal hemoglobin inducers. So remember that this is a condition with genetic with underlying genetic abnormalities, right? So in most cases, our idea is we know that we may not be able to get rid, at least for now, we will not be able to get rid of the underlying condition, but we can ameliorate its effects, right? So one of the ways to ameliorate the effects is to increase fetal hemoglobin, right, in the patient. And the way we can do that is by stimulating fetal hemoglobin production, right? Increases in fetal hemoglobin correlates with decreased sickling and adhesion, right? If you remember, we mentioned that the symptoms that even allow you to detect the condition usually come up when fetal hemoglobin is substituted with the sickle hemoglobin, right? So patients with low levels of fetal hemoglobin have more frequent crises and a higher mortality rate. And the medicine of choice is hydroxyurea. It's a cheap medicine. Unfortunately, because of low compliance, we still have a lot of patients with sickle cell disease that are dying or not getting access to the best treatment available. Hydroxyurea is a chemotherapeutic agent, has many effects on blood cells, including stimulation of fetal hemoglobin. It's indicated for patients with frequent painful episodes, severe symptomatic anemia, acute chest pain, or other vaso-occlusive complications. And it's usually started in patients at 15 milligrams per kg, single daily dose. Usually, as you're taking as the patient is taking their folic acid, they take their hydroxyurea dose at the same time. Now, decitabine may also be used in adults who do not respond to hydroxyurea. It's currently undergoing clinical evaluation, even though I think that, I think to a great extent, they're beginning to see some effects as well. So I think they're beginning to say they are comparable. I mean, I'll update this, once I get more information about that. Chronic transfusions are indicated for primary and secondary stroke prevention in children. That's transfusions of hydroxyurea, and they're usually given 3 to 4 weeks or as needed to maintain desired fetal hemoglobin levels. Sorry, that's not HBS. That should be HBF. Okay. Optimal duration is unknown, but risk can include alloimmunization, hyperviscosity, viral transmission. Oh, sorry. I have made a very serious mistake, please. This third point, sorry, there are 3 points here that I've mentioned. First is hydroxyurea. The second is use of decitabine, that's 5-azar-2-deoxycytidine. And then the third is chronic blood transfusion in children. So please, chronic blood transfusions, okay? Optimal duration is unknown. Risks can include alloimmunization, hyperviscosity, that's blood thickness becomes much more than what is commonly seen. Of course, you can adjust that by transfusing plasma, plain plasma without cells, right? But what it means is that as you're transfusing the patient with blood, you continually monitor blood viscosity and other states. And then the other challenge is hepatitis A and B transmission, right? And That is very important. Reason being that it wasn't too long ago that we were really screening for hepatitis in blood products. It wasn't too long ago. Now, of course, all blood is screened for viral pathogens, including HIV, hepatitis, and others, right? But we used to miss out on testing for hepatitis, for a long time. So patients who were getting blood products were easily just given hepatitis along the line. But now blood transfusion is safer and the risks are less, even though a few other risks still remain. For example, volume and ion overload, transfusion reactions, alloimmunization, and hyperviscosity risks still remain. Then there can also be allogenic hematopoietic stem cell transplantation, which is the only curative therapy for sickle cell disease. It is commonly thought that the best candidates are younger than 16 years, have severe complications, and have human leukocyte antigen matched donors. Risks must be carefully considered and include death, graft rejection, and secondary malignancies. There is ongoing, this service is being provided in the Sickle Cell Center opposite Lutz, but currently only for children because of limited resources. And those kids must be children that have some of these features, okay, before they can get access to that treatment. Now, this is a treatment algorithm. I'll have you go through it as well after this class. In terms of treatment of complications, how do we go about it? Educate patients to recognize conditions that require urgent evaluation, ensure homeostasis, oxygen saturation, and avoid exacerbations during acute illness. Red blood cell transfusions are indicated for acute exacerbation of baseline anemia in these conditions, severe occlusive episodes, and procedures requiring general anesthesia or ionic contrast media. Transfusions can be used in patients with complicated obstetric problems. That's patients with complicated childbirth, right? Refractory long leg ulcers or refractory and protracted painful episodes, right? So if a patient, you've given the, you've tried with treatments to reduce their pain, but then every time they're getting off the painkiller, their pain is chronic, then they may benefit from RBC transfusion. Promptly evaluate fevers that are higher than 38.5 and provide antibiotic coverage against the organisms we mentioned earlier. Usually ceftriaxone for outpatients and cefotaxime for inpatients. Initiate incentive spirometry. This helps you with appropriate fluid therapy, broad spectrum antibiotics, including macrolide or quinolone, and for hypoxia or acute distress, oxygen therapy in acute chest syndrome. Steroids and nitric oxide are being evaluated, but not yet approved for use in management of patients with sickle cell disease. Priapism is an important one. The incidence of priapism is higher in patients with sickle cell disease than in patients without sickle cell disease. It's been treated with analgesics, anti-anxiety agents, and vasoconstrictors to force blood out of the corpus cavernosum, right? So they can inject phenylephrine or epinephrine directly into the corpus cavernosum, into the muscle around the corpus cavernosum, right? And you can use dilators to relax the smooth muscle, tabutalin or hydralazine. If you must use hydralazine, then you must have intravascular blood pressure monitors available, because it can just crash the person's blood pressure as well. So it's important that you note this. Now, we talked about one of the complications, aplastic crisis, right? Treatment is primarily supportive. You can give blood transfusion for severe or symptomatic anemia. Now, for splenic sequestration, it's observation, especially for adults because they have milder episodes. You remember we mentioned that after repeated ischemic episodes, usually the patient goes into autosplenectomy, right? And so chronic transfusion can help delay this process. If the person has not developed autosplenectomy, then chronic transmission may help them reduce the ischemic insults. And if there's a life-threatening crisis, then splenectomy can be, that's a surgical process of removing the spleen can be done after repetitive episodes of a chronic hypersplenism. That's where the spleen becomes enlarged and does not even go back. Now for vaso-occlusive crisis, that's the one that is called sickle cell crisis, right? Fluid and analgesics are the mainstay of treatment. Ensure that you administer IV fluids or orally up to the normal maintenance that is required, right? Then you monitor the patient. If orally, of course, that means you're looking at about 6 liters. You are looking at the person drinking about 5 to 6 liters in a day, right, for adults. Then you need to monitor closely to also avoid volume overload, right? Empirically, you can provide antibiotic treatments because it may result from infection as well. It's advised to tailor analgesic therapy to the individual because of the variable frequency and severity of pain. So usually, you may not necessarily rely on the analgesic scale when you are treating patients with vaso-occlusive crisis. So you sometimes may need to find out how the person is experiencing the pain to adjust their access to pain relievers as necessary. You can use NSAIDs or paracetamol for mild to moderate pain. Then manage mild to moderate pain in an outpatient setting with weak opioids like codeine or hydrocodone, right? Of course, you are aware that now codeine is a controlled drug that we no longer have access to use over the counter as we used to before. So providing codeine may be a bit challenging in our current, but then DF118 is still available through sickle cell disease centers or specialist centers, and they're useful for patients with sickle cell disease, especially during crisis. Treat severe pain aggressively with an opioid such as morphine, hydromorphone, fentanyl, or methadone. The truth is, here in Nigeria, we have reserved morphine essentially for people with end-of-life treatment in cancer. So we do not even have them available for people with sickle cell disease currently. So sincerely, codeine is the highest analgesic currently accessible by people with sickle cell disease. Codeine, and then they also have access to petidine and what's the name of this other one? I'll try and remember the name before we finish this class, right? So those are the ones that are available for them currently. used to have tramadol available to them, but now it's been, because of the abuse, street level abuse of tramadol, it's been banned. Some dosage forms have been banned, but 50 milligram is still available as a controlled drug. Please note that 50 milligram tramadol is still available as a controlled drug. So it must be entered in the poisons book when you're dispensing as a pharmacist. Meperidine should be avoided because accumulation of non-meperidine metabolites can cause neurotoxicity in patients with a vaso-occlusive crisis. Treat severe pain with an IV opioid titrated to pain relief. Lord, what's the name of this one? Pentazocine, yes. Pentazocine is commonly used, right? IV pentazocine. And IV tramal is also available for use for pain relief. And they are administered on a scheduled basis with as-need dosing for breakthrough pain. Now, as-need dosing is not implemented in Nigeria because we do not yet have resources to monitor patient self-administration of those extra doses. So usually what we do is we only dose in a way that, okay, take for example, when we're dosing patients with codeine, right, at night, what it means is that if they take codeine before they go to bed, if they sleep for longer than 6 hours, they will wake up with pain, right? So that presents a problem for patients because sometimes they wake up with breakthrough pain, and that's very, very disturbing. Also, we sometimes are too suspicious. We suspect patients too easily, suspect them that they are already addicted. No. And meanwhile, those patients are actually suboptimally, they're having pain that is suboptimally controlled. So we need to do better as healthcare providers, really. So in terms of monitoring treatment outcomes, evaluate patients on a regular basis to establish baseline symptoms, monitor changes, and provide age-appropriate education that you need to continue to educate them about their medicine, about their health, and about their lifestyle. Then prevention as well. You need to continue to educate them. Then evaluate complete blood count and reticulocyte count every 3 to 6 months, up to 2 years of age, and every 6 to 12 months once they are older. Screen fetal hemoglobin level annually to help drive your how you are adjusting their dose of hydroxyurea, okay? Because that's the mainstay of treatment. Of course, in Nigeria, I forgot to add this. In Nigeria, you need, we also provide prophylaxis for malaria because that's one of the biggest diseases that brings an onset of vaso-occlusive crisis. So you need to provide prophylaxis for malaria regularly, right? So most patients use I'm coming. Let's just go on. I'll mention what they use now. So then you assess efficacy of the hydroxyurea by monitoring the number, severity, and duration of sickle cell crisis. The best prevention, like we mentioned earlier on, for the best prevention for vaso-occlusive crisis is taking hydroxyurea. So the malaria prevention I wanted to mention earlier on is Proguanil. Yeah, Proguanil, yes. Someone just mentioned it in the comment section, yeah. So the best, the daily prevention for malaria is usually Proguanil. So they take Proguanil with folic acid, and of course, they should also take hydroxyurea alongside. I think with that, we've come to the end of discussion about the treatments for sickle cell disease. Any questions? Any questions? So in practice, a test is not usually done. Yes, I mentioned vaccinations that are recommended for individuals with sickle cell disease. I mentioned vaccinations specifically recommended for individuals with sickle cell disease. I mentioned that it's in the notes, which I'm going to provide to you at the end of this lecture as well. So aside from that, like I said, we do a lot of treatments in practice that may not be we do a lot of treatment sometimes when we are not able to, do appropriate diagnosis. Can sulfadoxine pyrimethamine be used as prevention also? It is not commonly used. The most effective is daily Proguanil. The challenge with sulfadoxine pyrimethamine is also that it can lead to instability of the red blood cells as well. Pentazocine, codeine, pentazocine are commonly used in Nigeria. Codeine, pentazocine, commonly used in Nigeria. Codeine, pentazocine. And then, but of course, it's been banned right now, so it can only be obtained with prescription. Tramadol. Is there a way to learn the side effects of drugs, or we should just cram them? There's a way, really. As you learn the mechanism of action of drugs, you begin to understand their side effects as well. But some side effects are not completely explained by the mechanism of action. Should you cram? Cramming means reading to remember. Should you read to remember? Yes, you should. But if you cram and you do not, and you can't associate that memory properly, you will enter the exam hall and you won't remember. So, but cramming is a systematic way of reading to remember. So if that's what you mean, yes, you should cram. But if what you mean is read rote and not be able to recall what you wrote, then, no. I said something about penicillin being used. These things are a lot, sincerely. Pharmacy is a lot. Pharmacy is a whole lot. I said something about penicillin being used for treatment. Yes, I mentioned that, but that's in prophylaxis against infections. So yes, they are used, but usually in the early years, up to age of 5 or 6, and then you stop it. The reason why you use it up to the age of 5 or 6 is to ensure that you can prevent severe infections that can be life-threatening in that age range. Are there any areas of concentration? All these things are areas of concentration, apart from diagnosis. They are all areas of concentration. So, thank you very much. Want to say thank you again for giving me this time. I will see you during the in-course. Bye, everyone. I'll also update our Google class. I'll update our Google class with this lecture and the lecture notes as well. And then if you have further questions, you can, how do we put these things in our head? Read and associate them. Read and practice questions alongside. That's the best way, really. That's why I give you sample questions so that you can use those sample questions to generate more questions. And then, all right. So thank you, everyone. I will update our Google class latest by tomorrow with the lecture and the lecture notes. Bye.